This surgical video demonstrates the transcanal microscopic approach towards management of a deep posterior-superior retraction pocket, which is already adhered to the ossicles, the incudal long process with evidence of erosion of the same. One can visualize the stapedial head, and as you see, the posterior portion of the tympanic membrane displays a PSRP, and since it is fixed, there seems to be no requirement to put a grommet or any eustachian tuboplasty in such patients, and we normally resort to a transcanal endoscopic or microscopic approach to management of these pockets, which essentially is excision of the epithelium, complete elevation from the middle ear recesses and the ossicles, ossicular reconstruction, and cartilage grafting of the erstwhile retraction pocket. Now we are here using a self-retaining ear speculum, comes quite handy in giving us a tight grip onto the speculum, some amount of external canal dilatation. Using a Rosen's knife, a flap elevation has been done till the annulus level, and now once the annulus, the bony annulus is visible, we now resort to drilling using a coarse diamond burr onto the margin of the annulus or the posterior superior scutum to basically see the extent of the pocket, both superiorly and posteriorly, though we don't imagine it to be very deep. I mean, not that it's going too posteriorly towards the antrum, but basically the exposure of the middle ear posterior recesses and the ability to work on the ossicles very clearly. We use a small cotton ball to protect our tympanomeatal flap against the trauma of the drill. And as you see, a little bit of irrigation is used since you are using a transcanal approach. Excess irrigation will block our surgical field. Also, one must avoid using a very big suction because even that suction can traumatize the tympanomeatal flap and can lead to avulsion of the flap. So use of an appropriate sized burr. Here we are using a 3 mm coarse diamond burr for the purpose of a limited ichthycotomy, so to say, and a small 20 or 22 gauge suction tip to avoid suctioning and avulsing the tympanomeatal flap. Patience here is a virtue as to not to rush into this step, not to let the drill contact the ossicles or the TM flap. The purpose is just to sequentially and serially drill and to see if it is adequate or we need to drill further. Something akin to doing a stepedotomy, that is the amount of drilling we envisage here, not more than that most likely. And the most important part of these surgeries is basically you can divide this into three essential steps. One is the exposure. Second is the precise and complete removal of the squamous epithelium from the middle ear, including the ossicles if they are diseased or eroded. And third being the appropriate reconstruction of the middle ear mechanism, which is of course both the ossicular assembly and the tympanic membrane. As you see here, we are taking our time to drill and to see what is the amount of drilling required. If in such situations, though, the attic is clear in this patient and the disease is not going towards the attic, it is basically in the posterior mesotympanum, we are resorting to a totally transcanal approach. If one needs to do a limited superior ichthycotomy, one should not hesitate to use a small endoral incision. That allows you to do a very generous ichthycotomy as well with the endoral incision and hardly leaves a scar mark. Now we are using the Rosen's knife again to see if we can elevate the pocket in the middle ear. In these situations, one would have to transect the chora tympani clean and not avulse it because that causes more problems to the patient in the long term in terms of disturbed and altered taste. And one can also use endoscopes or angled instruments to clear the sinus tympani and the posterior mesotympanic recesses. So sharp dissection here using a sickle knife or a micro scissor comes quite handy. And again, patience is a very big virtue in this part of the surgery, as to the fact that you're not supposed to traumatize or avulse the stapes at all while doing this step. Once again, as we realize that the exposure is slightly less, we resort to some more drilling, superiorly as well as posteriorly, to be able to see more inside the middle ear. Now, as we see that our exposure is getting better with time, we start seeing the stapes head, as you can see there, and the glistening white squamous epithelium in the middle ear, which we are to clear. Now we come back to the sharp dissection using a sickle knife. One can use a slightly curved needle as well, or micro scissors to clear the epithelium from the middle ear here. Once again, one must not use a large suction or a big instrument, because large suction can exert a lot of pressure onto the stapes, or again tear your tympanomeatal flap. As you see, we are clearing the disease of the stapes head. As well as the Incus long process. We are still to establish if there is any any reasonable contact of the Incus long process or lenticular process to the stapes, or sometimes, as it happens, there's just a mere fibrous band that adheres the two, which is not conducting. This patient anyways has a conductive hearing loss on this side and has had history of ear discharge in the past. Sometimes a little irrigation in this step helps, because it clears off the thick accumulated blood, and we are able to obviously see better and continue with our surgery. Sharp instrumentation is crucial in clearing the disease, the squamous epithelium of the stapes head as well. And we generally avoid pulling using a microforceps, because sometimes the bite is inappropriate, or it may just hold on to the stapes head. It may get subluxated, thus creating a pedolymphatic fistula. As we increase our magnification, we start seeing the epithelium inside the middle ear, and gradually from superior to inferior and from posterior to anterior, we keep progressing on our clearance of the middle ear epithelium. On this step, one must always be very, very cautious in trying to reduce and minimize the amount of pressure or movements onto the stapes, because to avoid any gross trauma onto the stapes that can incite post-operative vertigo, and sometimes even mild to moderate permanent sensory hearing loss. Now, as we have more or less cleared the stapes, the middle ear recesses in the sinus tympani is still to be seen and cleared, as well as the medial wall of the middle ear posteriorly, which has to be cleaned. Now, it cannot be overemphasized how important clearing every bit of squamous epithelium from middle ear is, because if it does not, then it leads to a residual nitrogenic cholesteatoma in the middle ear, which post a cartilage tympanoplasty one would not be able to visualize. Once again, as we see that we are slightly restricted in the exposure, we resume our drilling to increase slightly the posterior exposure. That not only gives us a better vision with the microscope inside, as well as also gives a fraction of a millimeter more space for the instruments to move around without creating a conflict. Once again, drilling around just along the stapes below, one has to be very, very cautious as to not let the drill slip inside or contact the mobile stapes. That would surely cause a permanent and unfortunate hearing loss. Now, that is why the reason that these pockets should be generally operated as soon as they demonstrate any contact with the incus, because the moment they go further than that or medial to that and involve the stapes head, clearing it becomes a tedious task, and it's fraught with more complications. So any irreversible contact or with the incus on posterior-superior retraction should prompt early surgery to avoid loss of ossicular function. As we see, most of the middle ear appears to be clean except for a little speck linear tissue that lies on the promontory, which also would be cleared. The last part would be basically there in the sinus tympani, for which we could use even a cotton ball or an annulus fish elevator, or nowadays we have custom made sinus tympani elevators, which are of a certain dimension to suit this part of the section. Now, as we see, here we're using a plaster knife to basically just clear the disease from the sinus tympani region. Now what we see is that the incus is having a very bare minimum contact with the stapes, and you can see movement of the incus hardly leads to any movement in the stapes because it's a very small shred of band that connects the two. So our plan would be to clear the incus, remove it from this middle ear, so as to be very sure that there is no epithelium superior to the stapes. And since we have cleared the epithelium from the incus, also to reshape the same and perform a type 3b tympanoplasty, where we use the incus to be placed on the capitulum of the stapes. Now, once this step is done, we resort to putting the flap back and seeing what kind of dimensions we have and what is the size of the defect that we have created post excision of the retraction pocket. Now we resort to harvesting of the tragal cartilage, and what we will do is give a medial incision just below the dome. The dome of the tragus must never ever be compromised for the sake of this. It leads to a very poor cosmetic deformity and is unacceptable. The incision must always be given 2 to 3 millimeters below the medial to the dome of the tragus, and a reasonable amount of cartilage can be extracted from this thing, and the wound closed using vicryl sutures. We do not recommend using silk here because they don't have to be removed. And now we use the incus and reshape it using 2 millimeter or sometimes 1.5 millimeter diamond burr under ample amount of irrigation to create a socket for the stapes head. Using the Autologous Incus also gives you an advantage of creating a reasonable amount of middle ear space as compared to using a straightforward piece of cartilage over the stapes. And like you see that with the small socket that we have made with the drill, the incus sits very comfortably onto the stapes and is not even having too much play around. The remnant of the long process has been drilled as well as part of the short process. We do not want to use the short process medial to the malleus here because the malleus handle is slightly medialized. So what our plan would be to basically just use a full thickness cartilage. First we use the tragal perichondrium so that it goes medial to the malleus handle. We do not want to have any epithelium grow inwards in the middle ear from any space that remains. So post the placement of the Autologous Incus, which has been grafted onto the stapes head, we use a tragal perichondrium to cover the same and to cover the defect that was created using the PSRP excision, and taking it very carefully medial to the handle of malleus as well as the tympanic membrane remnant, so that the epithelialization can happen on this graft and the epithelium, squamous epithelium, does not get any crevice or any gap to percolate into the middle ear. Now, once that has been done, this perichondrium can be put back anteriorly so that it assumes contact through surface tension with the uh, tympanomeatal flap remnant. And now inferiorly, we can put some small pieces of gel foam to stabilize the cartilage trough, which we have shaped in a semilunar sort of a fashion. And this cartilage graft that we would be using would be with the one side bare and one side perichondrium attached. The perichondrium side would be facing the external aortic canal and the TM flap, and then the bare side would be facing the uh, incus that has been put onto the stapes head. Now, once we have put a little small portion of gel foam, we don't want to overfill it because then that leads to a gross bulge of the cartilage. Now we put this semilunar shaped cartilage with the attached perichondrium laterally. It has been sized to perfection. That's very important because if it's too small, it's going to float. And if it's too big, it's going to just rigidly block the entire middle layer and will not conduct. So once it has been shaped correct, you see that it sits back very, very comfortably inside the middle layer onto the incus. And now all that remains would be to just put back the tympanomeatal flap and the perichondrium composite and see if everything is well adhered with each other through surface tension. Again, one has to be cautious to use the smaller suction, maybe 22 French or 24 French, so as to not suck onto the tympanomeatal flap vigorously or remove your perichondrium graft, because that would just end up wasting time. You got to do all that again. And once you're sure that the tragal cartilage graft is not impinging or is not firmly adhering to any portion of the canal wall, one can put the tympanomeatal flap back gradually and see if the entire portion of this flap and graft assembly is sitting back in the way that we desire to. You can see how the perichondrium sits nicely. Once with a little dabbing, it's if one is clear that there is no gaps anywhere, we can just resume to packing the external aortic canal with the gel foam, dry gel foam pieces first, so as to keep everything in place.